Hello, and thank you for joining this session as part of our webinar educational series titled Living with Psoriatic Arthritis. My name is Brenda DeLauder, and I am the Executive Director with the Canadian Spondyloarthritis Association, and I am delighted to be the moderator for today's event. Please feel free to let us know where you're joining us from, and you can use the chat feature for that. Just before we move into this session, I do want to provide a trigger warning as there may be some images and commentary that may be difficult for some. If this is the case, please be mindful on what you personally need if this does arise. We understand and we value triggers can be very individualized. Again, please share with us where you are joining from in the country. I would also like to begin by acknowledging the Indigenous peoples of all of the lands that we are on today. While we meet virtually today, we do take a moment to acknowledge the importance of the land, which we each call home. I am coming to you from the region of Hamilton in Ontario, and this is a part of the treaty lands and territory of the Mississaugas of the Credit. We recognize that those joining us are doing so from across various lands and territories. For thousands of years, Indigenous peoples inhabited and cared for these lands and continue to do so today. We are grateful to have the opportunity to work and live on this land, and by doing so, give our respect to its first inhabitants. I also would like to provide a disclaimer that the information provided by the Canadian Spondyloarthritis Association is not designed or intended to constitute medical advice or to be used for diagnosis purposes. Due to unique individual needs and medical history, please consult your own healthcare provider who will be able to determine the best appropriateness of information for your specific situation and can assist you in making decisions regarding treatment and medication. So most of us here are all too familiar with spondyloarthritis, and many have seen this slide before. The term spondyloarthritis, SPA or SPA, really describes this group of chronic inflammatory arthritic diseases, and they feature inflammation of the spine, the gastrointestinal tract. These conditions, they are disease. We also provide awareness and patient education, as well as advocacy to influence policy. And today, as one of those objectives, we are bringing to you this educational webinar segment. I also want to take a moment to extend our thanks and appreciation to some of our partners. With their support, we are able to provide you with these types of opportunities to better inform community and to support community. And we wish to disclose with full transparency that the funders of this series, and we want to acknowledge them, and without them, we couldn't make this possible. So thank you. I now welcome our expert guest to join me in a moment. And as I do so, thanks to those who have submitted questions in advance of this session. For those who wish to ask questions during the session live here today, please use the Zoom Q&A feature in chat. We'll focus on moving through the questions submitted in advance first, and we will try our very best to address everyone's questions. Welcome, Dr. Chandran. It's really great to have you here with us today to share your insight.
Thank you. Thank you, Brenda, and thank you to the CSA for inviting me.
I will pass the screen over to you, and I'll let you move forward with your slides and sharing your incredible expertise.
Thanks, Brenda. Let's have my slide on. Yeah, there we go. So my disclosures, I get support from some of the companies that make medications for psoriatic arthritis, and so that's just over here. I also get royalties for writing a couple of books on psoriatic arthritis from the Oxford University Press, and also salary support from the hospital and the university, as well as many agencies that support my research. My wife also works for AstraZeneca, although we're not going to talk about any product that AstraZeneca makes today. So what I would like to do in the next, say, half an hour or so is to talk about psoriatic arthritis, and also how it is related to the spondyloarthritis concept. We'll talk about the clinical features, how PSA or psoriatic arthritis is diagnosed, how it's managed, and what some of the unmet needs are. So I'm sorry for the formatting things. I think when you upload to the platform, this happens. But anyway, what is psoriatic arthritis? It's a spondyloarthritis, SPA, SPA, which is associated with psoriasis. As Brenda mentioned, spondyloarthritis is associated with inflammation not just in the musculoskeletal structures like the joints or the back or the entheses, but also skin and other mucosal surfaces. For example, on the skin, you can have psoriasis. You can also have some other skin conditions. In the gut, you can have inflammatory bowel disease, and in the eye, you can have uveitis. So this group of diseases affects the joints as well as the other structures that I've mentioned. And when it affects psoriasis, then we call it psoriatic arthritis. So you know what spondyloarthritis is. The spondyloarthritis affects the most important or the most characteristic structure that is affected is the spine. So you can have involvement of the sacroiliac joints, that's depicted in the picture here, but also the spine per se. The sacroiliac joints is in the pelvis at the bottom here, but the spine, as you know, extends right from the lower part of your trunk right up to the neck, and the whole spine could be affected. In addition, these diseases affect what we call the enthesis, where the tendons and ligaments attach to bone. It can, of course, cause arthritis when there is swelling and inflammation inside a joint. And some of the interesting features are also depicted on this picture. Dactylitis, swelling of the entire finger or toe, sometimes called sausage digit. So these are the musculoskeletal manifestations. Not everybody has all these manifestations, thankfully. Some people may only have a dactylitic finger or may only have a swollen knee. But as time goes and without treatment, you might have a more chronic cause and additional joints being affected. So any joint in the body can be affected. The whole spine could be affected. You can have dactylitis and significant enthesitis in multiple sites across the body. And of course, in addition to all this, there is the involvement of the skin and the gut and the eyes. Again, and not in everybody, but in a significant proportion of patients. And because not everybody has all these manifestations, there's a lot of heterogeneity, and I'll speak about that a little bit in my talk. What are the other closely related autoimmune diseases associated with spondyloarthritis? I mentioned skin, typically psoriasis, gut, inflammatory bowel disease, Crohn's disease, and ulcerative colitis, and eyes uveitis. Um, these are the most recognized and common. There are other forms of skin disease and occasionally gut disease that can affect patients with spondyloarthritis. Other organ systems could also be affected, although not that commonly, including the kidneys. So when you talk about psoriatic arthritis, we're talking about an inflammatory arthritis that happens in patients with psoriasis. Now, most of the time, 70, 80% of the time, you get the skin disease first and then the joint disease. And that can happen anytime after the onset of skin disease. And in a proportion, 10 to 15%, you get the joint disease first and the skin disease later. And so initially, when the joint disease happens, it might be difficult to kind of give a label or make a proper diagnosis because the skin disease is not present. But when the skin disease occurs, then it becomes a little more clear. Many of the patients with joint disease but no skin disease have family members with the skin disease, with psoriasis, and so that helps in the diagnosis. But typically, you get the skin disease first in the 20s or 30s, and then on average in about 10 years. But it's not that, after 10 years you're not likely to get it, that your arthritis can develop anytime after the onset of skin disease. And that gives us an opportunity to understand why some people with psoriasis, not everybody gets psoriatic arthritis. It's only about maximum 30%, I would say, get psoriatic arthritis. So why do 30% get it, 70% do not get it? And why do some people get it sooner, some people later? And what are the reasons for getting arthritis? We could study that, understand that, and then hopefully intervene to treat the arthritis early or even prevent the development of psoriatic arthritis. And this picture here, which I've taken from a review by a colleague of mine from New York, talks about how various factors could lead to the development of psoriatic arthritis. And as you would imagine, these things happen within your body without you knowing it. And we think about the evolution as having just psoriasis without musculoskeletal inflammation. We think about preclinical psoriatic arthritis, where there are immune activation happening in the body, but otherwise you're not feeling anything about it. Then you reach a state of subclinical disease, where if you look carefully, here we have shown a picture of an ultrasound, where there is inflammation in the joints, but on clinical examination, there is really no findings, and the patient at this stage also does not experience a lot of symptoms. Later on, you get some joint pain, some fatigue, but if you go to a physician, they may not actually see anything. So we call that a prodromal phase. And then you can have an overt arthritis where you have swollen joints or swollen dactylitic finger or significant backache, which is confirmed on an MRI, for example. So evolution is proposed to happen in this phase, and we have some evidence for this. Some people, it may take a long time, and in some, it could be a rapid evolution. And why that is so is not all that clear. Now, since most people have psoriasis first, and I said it gives us an opportunity to investigate or understand the disease better, we have been looking at if the type of psoriasis or the extent of psoriasis helps us predict the future development of psoriatic arthritis. And so what we know is that if you have psoriasis in the scalp, or if you have psoriasis in the between the butt cheeks, the intergluteal region or the natal cleft, you are more likely to get psoriatic. It increases the risk of developing psoriatic arthritis. For example, scalp increases the risk about 4 times, intergluteal psoriasis about 2 times, and also the severity of psoriasis. If they are very high severities, we measure psoriasis severity by body surface area or by a measure called PASI. The higher that is, you're more likely to get psoriatic arthritis. So in my practice, patients who have lot of psoriasis, who have nail psoriasis, who have scalp and integral psoriasis, I see them at least once a year and educate them to say, well, if you develop any joint pain, do reach out to me for evaluation. As I mentioned, nail disease is another important risk factor for psoriatic arthritis. About 50% of patients with psoriasis might have nail disease, but they are more likely to get psoriatic arthritis. And so if you have psoriasis and nail disease and joint pain, that needs to be evaluated. Nail disease, there are many types of nail disease, like nail pitting, or which you can see on the picture here. There's also something called onycholysis, separation of the nail from the nail bed, as you can see the picture here. With you can see that the nail is lifted. These features are predictive of psoriatic arthritis. Now, those are what we call anatomical factors, or the type of psoriasis. The nail disease tells you that you have this form of psoriasis, you're more likely to get psoriatic arthritis. The other things that we are interested in are genetic and environmental risk factors. If you really look for genetic factors that differentiate psoriatic arthritis from psoriasis, there are not that many, primarily because the psoriasis is very much a genetic immune-mediated disease. But the joints, it's controversial. There are some features that are different between psoriasis and PSA from a gene point of view. But my strong belief is that on a genetic background of psoriasis, when you have an environmental insult, you're more likely to get psoriatic arthritis. So from an arthritis point of view, the environmental factors may be more important than the genetic factors. And what are these environmental factors? One important one is mechanical trauma. So injuries to a joint or even elsewhere is more likely to be seen in patients with psoriasis who later develop psoriatic arthritis. So that's important. Smoking is another important risk factor. Smoking increases your risk of getting psoriasis and also psoriatic arthritis. Other major environmental factor is obesity. We know that people who are overweight and obese are more likely to get psoriasis, and psoriasis patients who are obese are more likely to get psoriatic arthritis. And so losing weight may be one of the ways of preventing the development of psoriatic arthritis. I know that's not easy, but maybe an appropriate diet and exercise would help you improve your health and prevent that transition from psoriasis to psoriatic arthritis. I talked about trauma or injury, and we call this, a Koebner phenomenon when it happens in the skin. So people with psoriasis know that if not all of them, but a significant proportion of patients with psoriasis who injure the skin, they get a cut or say surgery, for example, psoriasis develops in that injured site, after a fall or for a cut by a knife, surgical scar, etc. So that's what we call Koebner phenomenon. And because injuries to the musculoskeletal structure lead to development of arthritis in that joint, we call this deep Koebner phenomenon. So in at least a proportion of patients, there's that injury that triggers the arthritis, and deep Koebner phenomenon happens. And the question is, because the joints that are affected by psoriatic arthritis are the joints where there is a lot of biomechanical stress, maybe it's that minor micro injuries that happen in day-to-day life in everybody triggers onset of psoriatic arthritis in a person who has psoriasis and is genetically predisposed to it. So that micro trauma and over trauma are important risk factors for psoriatic arthritis. We have shown that, as I mentioned, obesity predicts psoriasis and psoriatic arthritis. This is a study that demonstrates that. And so there is enough research to indicate that the factors that I mentioned are important in the development of psoriatic arthritis. Now, this picture here serves to illustrate the the great heterogeneity of disease that I alluded to earlier. The psoriasis itself is very heterogeneous. Different types of psoriasis: pustular, non-pustular, palmoplantar, flexural, extensor, sebo-psoriasis, etc. Then there's nail disease. Only some people with psoriasis have nail disease, but if you have nail disease, you're more likely to get psoriatic arthritis. The nail disease also can be quite heterogeneous. The joint involvement can be quite heterogeneous. It can affect any joint, particularly the end joints of the finger, the hands and toes. It can be quite severe, as shown in this picture over here, with a lot of destruction. It can affect the spine, as well as the enthesial sites, for example, the heel, and I'll talk about it a little later, and also the eye disease and the inflammatory bowel disease that is shown in the bottom left picture over here. And so you can see how these various manifestations are heterogeneous, and so no one patient with psoriatic arthritis might look like another patient. And so when you examine patients with psoriasis who might have psoriatic arthritis, you really have to carefully evaluate all these features. So some pictures here. The joints can be inflamed, and the interesting fact is that the inflammation in psoriatic joint is actually not just inside the joint, but also outside in the capsule and the tendons near the joint. And that's why when you look at a swollen joint in a patient with psoriasis, with psoriatic arthritis, you might see that the skin is more inflamed. There's some redness, what we call erythema, around these inflamed joints. Now, in other forms of inflammatory arthritis, typically rheumatoid arthritis, you don't see that redness. The joint, because the inflammation is right inside the joint, and the skin is far away. Whereas in psoriatic inflammation, it's not just within the joint, it's also outside the joint. And then and this is shown on the left over here. And over time, without treatment, you can get deformities and as well as destruction of the bone. That's why these fingers here in the pictures on the right are actually shortened. This is what we call arthritis mutilans. Thankfully, we don't see it that often, especially with more advanced therapy now. But a lot of patients in the 70s and 80s, when this condition was properly, was recognized and described, there were patients with severe destruction, as you can see in these pictures here. Back involvement is also a big important feature. It may not be as painful as we have in other forms of spondyloarthritis, like ankylosing spondylitis and axial spondyloarthritis. However, even if not, because of all the other manifestations being present, it carries a significant burden. And even if the back is not very painful, people with back involvement, which we diagnose mainly by imaging, like X-rays and MRI, tend to have more severe involvement of the other joints, like the hands and feet. So back involvement by itself is a problem, but even if not symptomatic, could be a manifestation of severity, and therefore a marker that we should be looking for, and patients with back involvement should be more aggressively monitored and treated. I talked about sausage finger or dactylitis. This is when the whole finger or toe is swollen, as shown in this pictures over here. And this is very typical. And sometimes when only that is present, it's misdiagnosed as infection. I've had patients who have been treated for months with antibiotics because they had a red swollen toe, which was not getting well with anti-inflammatories. Enthesitis is an interesting phenomenon. There is inflammation where the tendon or ligaments attached to bone. The most common site is at the heel. This is where the Achilles tendon attaches to the bone. When the tendon is inflamed, over here where my cursor is, that's tendinitis of the Achilles tendon. That's common. It's seen in people who exercise, who run. But enthesitis, where the inflammation of where the tendon attaches to bone, that's more specific for spondyloarthritis, and often not easy to distinguish between mechanical causes and from inflammation due to spondyloarthritis. And we really, for a proper diagnosis, you need to do an ultrasound or even an MRI. Similar features can happen where the plantar fascia attaches to the calcaneum and causes plantar fasciitis. This pain can occur in other sites, enthesial sites. There are hundreds of entheses across your body, and so you might have pain around the elbows, similar to tennis elbow and golfer's elbow. You can have pain around the shoulder, chest wall pain, a tightness in your chest that makes it difficult to breathe, as well as pain around your hips and then on your pelvic bone. So multiple sites could be affected, and sometimes difficult to diagnose. So typical psoriasis and the nail changes that I mentioned, and the clinical features that I mentioned earlier in the eye and the gut. So all these features are important, and what I talked to until now was all the inflammatory features that make it very specific for psoriatic arthritis. But there are other things that go along with the inflammation in the skin, eyes, gut, and the joints, and that's what we call associated diseases or comorbidities, and that's a big factor, especially in psoriatic arthritis. As I mentioned earlier, obesity, metabolic syndrome, and are common, and diabetes is also common in our patients. And as I mentioned, obesity makes it more likely to get psoriasis and psoriatic arthritis. And so an important part of management of psoriatic disease is working on trying to improve metabolic syndrome, obesity, and if diabetes is present, managing that. And for that, of course, we need big help from our family physicians. These comorbidities drive atherosclerosis. The inflammation from the joint and skin inflammation drives atherosclerosis, and that ultimately leads to heart attacks and stroke. And we know that patients with psoriatic arthritis, patients with psoriasis, as well as other spondyloarthritis, especially ankylosing spondylitis, have a higher prevalence of cardiovascular disease and have heart attacks and strokes. And the inflammation by itself drives some of these, drives atherosclerosis. And so in addition to, say, diabetes and high cholesterol and smoking, we also have the additional risk caused by the inflammation. And so for the management of cardiovascular disease, we need to really be strict in managing the traditional risk factors, and as well as work on getting the inflammation as low as possible. One other important feature which patients have always been talked about, and I think to an extent ignored by the mainstream medical community, has been mental health issues. There's a high prevalence of anxiety and depression. There's a lot of chronic pain, as we know, but also fatigue, poor sleep, and the stigma associated with the joint and skin disease. So these are all features of this disease. Now, when you look at patients with psoriasis, about half of them complain of joint pain, but not all of them have psoriatic arthritis. So other musculoskeletal problems like osteoarthritis, tendinitis, and enthesopathy, which is not inflammatory, are also associated with psoriasis. And one of the challenges we rheumatologists have is to distinguish the non-inflammatory muscle pain from the inflammatory muscle pain, because the treatment of that is going to be quite different. The inflammatory one, psoriatic arthritis, you can use the treatments that we have to bring down inflammation, whereas the non-inflammatory musculoskeletal pain should be managed with physiotherapy, exercise, good sleep, all of that, right? So we need a combination of both for managing the overall musculoskeletal health of patients with psoriasis. What we know is early diagnosis leads to better outcome. There are studies done at our own center here in Toronto and in Ireland that proves it. And this slide here is just to give numbers to that. But bottom line, according to the study, especially from Ireland, even a delay of 6 months in diagnosis has consequences. So we really have to strive to get the diagnosis made within the first few months for the best outcome. And that's a problem because there is a significant diagnostic delay. So this is, we don't have data from here as of now. We're working towards it, but this is the data from the Mayo Clinic the Rochester Epidemiology Center, and the median time from symptom onset to physician diagnosis has been 2.5 years for almost the last 20 years, 2 decades, despite all the awareness. And as you can see in this picture here, the line is flat. There has been no improvement, at least in the Rochester, Olmsted County, Minnesota. And I think we are doing a little better now, but I think there are big discrepancies, variations across our country, and within our province also. So lots of work to be done to get the diagnosis early. What can you do to make the diagnosis early? One good thing is that the psoriasis tends to happen first. So when you see your dermatologist, your family doctor talking about joint disease, and we have developed some screening questionnaires that we can use to screen, and the family physicians or dermatologists can use to screen. They don't have to fill it up. You fill it up and give it to them, and hopefully that triggers an assessment and a referral, if appropriate. We do have combined dermatology-rheumatology clinics where we work with the dermatologist together at the same time. We're trying to develop this across North America through the Pac-Man project, PPAC-Man, right? The Psoriasis and Psoriatic Arthritis Multi-Center Advancement Network. And there are many ways you can do a combined clinic, right? Ideally, both together seeing the patient at the same time, which might be challenging, because one reason getting two people into the same room is difficult. Dermatologists typically take less than 5 minutes to do an assessment. We take, say, half an hour, and so there's that difficulty. But now with more technology, we could use, say, the virtual tools that we have to kind of involve the dermatologist, and the dermatologist can involve the rheumatologist for early diagnosis, but also education of the patients as well as the trainees who are going through our respective clinics. Now, the question, of course, in your mind is, how is psoriatic arthritis diagnosed? I talked a lot about heterogeneity and the manifestations being quite diverse, and there are difficulties distinguishing between usual aches and pains versus inflammatory disease. So it is challenging, and therefore the diagnosis should be made by somebody who's trained in it, so typically a rheumatologist. And the big challenge is that there is no diagnostic test. The blood test for inflammation may be normal. So the diagnosis hinges upon a proper detailed history, a good physical exam, looking at not just the joints, but the enthesis, evaluating the back, looking at the lab work for evidence of inflammation. Now, if it is present, that's helpful. If it is absent, it does not rule out psoriatic arthritis. And then we do a lot of imaging, because that gives us more quote unquote objective evidence. So we do X-rays to look for joint damage. We do ultrasounds to look for inflammation. We do MRIs for looking, again, at focus sites. If we suspect something going on in the wrist, we might do an MRI of the wrist. Ultrasound we can do at multiple sites at the same time. Some people do it in the clinic during the physical assessment, or may call you back the next week for an ultrasound. They might have an ultrasound clinic to do that assessment. So when you take all that into account to say, yes, there is inflammatory disease involving the joints or the spine or the enthesis in a pattern that is typical for psoriatic arthritis and not other inflammatory diseases. You could have gout, you could have rheumatoid arthritis that can happen along with psoriasis. So by looking at the pattern, then we know what we see is actually consistent with psoriatic arthritis. And then, of course, the presence of psoriasis helps, but that you don't have to have psoriasis to have psoriatic arthritis. But most patients do have it. So the diagnosis is not easy, and that's probably one of the reasons for a lot of delayed diagnosis and the impact that has on our patients. So once a diagnosis is made, then you have to manage the disease. An important thing is education. Now, some things that like we are doing today through the CSA is important. All the brochures are important. Awareness is important. When you have psoriasis, I might, it's not just a skin disease. There are other organs that could be affected. I could have arthritis. It's something that all psoriasis patients should know, so that if they develop new onset persistent joint pain, it's best to get that evaluated. General health measures, stop smoking, regular exercise, appropriate diet, appropriate sleep, stress management, all that's important for any inflammatory condition, but especially for psoriatic arthritis. And then if the symptoms are significant, then medications do provide significant benefit. And there are many classes of medications that we use. Some are quite old, like the anti-inflammatories and the conventional immunomodulatory drugs. So for joints pain, we typically give anti-inflammatories, appropriate doses. We don't like to get long-term. If somebody requests anti-inflammatories long-term, maybe you should try other medications to get them off that. We generally don't give steroids orally or by intramuscular injections. Prefer to give it intra-articular. If there is a joint that is swollen, an injection to that joint helps. If a joint is swollen, removing that fluid and examining it also helps in identifying inflammatory disease. And if there is persistent inflammation, then usually the first step in the management is to go on what we call conventional synthetic immunomodulated drugs like methotrexate, which can be taken by injections or by tablet, sulfasalazine, leflunomide. These are tablets. These are conventional drugs. They are available for many years. We know their side effects. They're relatively cheap, and many patients do respond to it. And ideally, the patient should be seen in a setting where you can have access to both rheumatologists and dermatologists. And if there are other manifestations like eye involvement and gut involvement, then the ophthalmologist and a gastroenterologist and other specialists. A family physician who's actually very engaged in monitoring you would be really helpful, because, as I mentioned, we got to also take care of, smoking cessation, weight loss, management of diabetes, hyperlipidemia, which is, as I mentioned, quite common in our patients with psoriatic arthritis. And then, if the regular measures that I mentioned in the previous slide does not help, that's when we think of escalating therapies into more advanced therapies. There are a lot of that available now. The anti-TNF agents have been present. We've been using it for almost 20 years now, and they're very effective. And there is a soluble receptor, etanercept, and then anti-TNF antibodies, infliximab, adalimumab, golimumab, and certolizumab pegol. For some of them, like etanercept, infliximab, and adalimumab, now we have biosimilars, so the price has come down. Insurance companies, as well as our drug benefit programs, provincial ones, are mandating our patients be switched, which I think is fine. It helps us to reduce costs and reinvest that saving into further better healthcare. And so anti-TNF agents are one of the most important drugs. I think in our clinic we use that more than any other drug in patients who have psoriatic arthritis not responding to conventional therapy. There are other non-anti-TNF biologics that are available. One of them is abatacept. We don't use that often. It's a common drug for rheumatoid arthritis, but in occasional patients, we do use that drug. But the other drugs that I mentioned over here, which target cytokines in the Th17 pathway, like ustekinumab, secukinumab, ixekizumab, guselkumab, and risankizumab, are available and are excellent drugs for the management of psoriatic arthritis. And they're also much more effective than anti-TNF drugs for the psoriasis. So patients with severe psoriasis, we would be going to drugs in these drugs, especially secukinumab, ixekizumab, and guselkumab, which are specifically indicated for psoriatic arthritis and also have excellent response on the skin. We use these drugs for these patients, and the skin responds really well. The arthritis response is generally similar to the anti-TNF therapy. More recently, we have oral drugs that are what we call, these drugs are much more effective than the conventional synthetic. So we call them targeted synthetic drugs, especially the JAK inhibitors, tofacitinib and upadacitinib. And so they're quite effective for the arthritis. They're not as good for the skin, but for the joints, they're excellent. Then there is also another targeted therapy called apremilast, which is not as effective as the other drugs on this slide, but in a subset of patients do really well, and may also be associated with some weight loss. So these are the drugs that we have, and there are many factors that come into play when we try to decide which therapy to use for a particular patient. How do you monitor patients? We ask patients about pain, how they are feeling, how much fatigue they have. On a physical exam, we look at the extent of psoriasis. We count the number of inflamed joints, count the tender enthesis, if there are any dactylitis, how much of back pain they have. We also look after, the lipid profile, blood sugar, blood pressure, and how much the weight is. All that needs to be monitored. And then for the treatment per se, before going on drugs, we do a screen for underlying infections, the status of the liver and kidney, etc. And then for some drugs, we need to pre-screen for any underlying viral infections. And then we monitor, especially with methotrexate, leflunomide, as well as the JAK inhibitors. We do a blood count every couple of months. We have to look at the lipids, especially for the JAK inhibitors. For the anti-TNF and other biologic agents, at baseline, we rule out tuberculosis and other infections. The blood monitoring is not really that intense as the other drugs. Initially, maybe once every 3 months, and subsequently once every 6 months is good enough. But the important risk is about infections, and so we have to be careful about that. And if there is an infection, don't take the drug if you're supposed to take it. Take antibiotics if required, if indicated. And so that's important. Get all your vaccinations done. And with these immunosuppressants, we like to avoid live vaccines. So if you are scheduled to get any live vaccine, then get it before you start these drugs. For apremilast, no routine monitoring is actually recommended. How do you, from a treatment perspective, our organizations have come up with recommendations. I'm not going through all of them, but I would say that our aim is to look at all the different domains of disease, the skin, the back, joints, enthesis, and try to bring down the disease activity in all domains using the drug that works for all these domains. We have, as I mentioned, consider all the domains, we look at the comorbidities, but at the end of the day, the therapy, the decision for which drug to use is individualized and is made jointly by the clinician and the patient. So shared decision making is very important so that we are all on the same page and looking for the best outcomes for our patients. This is the GRAPPA treatment schema, depending on which structure is involved and which drug should be used. It's for your physicians. If they've not seen it, our organization, GRAPPA, has come up with patient summaries for these treatment recommendations so that you know when you go to your rheumatologist, hey, this is what is recommended. So you're all on the same page, and you can, when you talk about shared decision making, we're all on the same page, right? So that's important, and so this helps in it. And depending on what the most important manifestation is it back, or is it the skin, or the joints? There are some recommendations on which drug to start, which group of drugs to start first. So that's what the GRAPPA treatment recommendations are, and I'm sure your physicians would know about it. And finally, talking about the future, there are a lot of developments that's happening. Number one, could we prevent psoriatic arthritis? As I said, you get psoriasis first, and there's all those phases before you get over psoriatic arthritis. So maybe patients with psoriasis, if we can do something that can prevent the development of psoriatic arthritis. There is a clinical trial going on with a particular drug, but maybe there are other interventions that could be done. So we are thinking of prevention now, which is great. Other thing is, like I mentioned, there's no diagnostic tests. So could we develop a diagnostic test? We're doing heavy research in that area, and hopefully we'll have a diagnostic tests that we can actually start testing sometime next year. Then the most important thing, I guess, is already when you have the disease, is what drug to choose. And we have so many options now. What is the right drug to choose for the right patient at the right time? So-called precision medicine. That's a difficult task. We're working towards it in many other areas like oncology. That's happening, and hopefully we can have that in psoriatic arthritis too. We do have a lot of drugs that I mentioned, but we still need more drugs. There are patients who, despite trying multiple biologics, are not doing well. And so there are some new drugs coming soon into the psoriatic arthritis world, deucravacitinib and bimekizumab. And incidentally, they're already available for our psoriasis patients, and hopefully we'll have it for our psoriatic arthritis patients soon. Is one biologic or one type of drug sufficient? We do combine methotrexate occasionally when needed to, but could we combine biologics and advanced therapies? There are studies going on to do that now. The concern, of course, is side effects and infections. We'll have to wait and see. But some of the newer biologics are very safe. So personally speaking, with some of the biologics, I don't think infections are going to be a problem, but that's just my opinion. We're going to do studies combining the drugs to see, do they provide additional benefit, and is there any downside? Cost remains a concern. The introduction of biosimilars have reduced the costs. Hopefully, with more targeted oral therapies that are much more cheaper to make, I think we can also develop cheaper therapies that are very effective. And finally, what patients and CSA can do: awareness, both among the general public, psoriasis patients, primary care, dermatologists. Sometimes they're not aware of all these things that are happening. Blood tests are not really useful, so doing a proper assessment would be good. A clinical assessment would be nice, and be proactive about it. So even if you're going to the dermatologist, if you have joint pain, say, I have psoriasis, I have joint pain, should I not be evaluated for psoriatic arthritis? If you put that question to your dermatologist or primary care physician, you probably get referred, or at least get properly evaluated there. Who are at higher risk? Those with severe psoriasis, those with nail psoriasis are particularly prominent. As I mentioned, scalp is also important. If you have a family member with psoriatic arthritis, yes, that's at high risk. And as I mentioned, when you see your family doctor or your dermatologist, do mention your joint pain and enthesial pain and ask for a referral if appropriate. And finally, if you get to a rheumatologist, mention all your symptoms, with joints. Do you have sausage digit, back pain, neck pain, elbow pain, heel pain? All are very important. Even if the rheumatologist does not ask you to disrobe so allow them to evaluate the skin and the back, remove your shoes and socks so the feet can be evaluated. A lot of disease begins in the feet, and sometimes in the interest of time or whatever, feet are not examined properly, and opportunity for diagnosis is missed. Whatever associated conditions you have should be mentioned in what treatment that you're on. And if you can come with a list of medications with the start and stop dates and how you responded to it, that would be wonderful. If you've already been diagnosed before and treated, not just the psoriatic arthritis, but psoriasis. And with that, I'll stop. I'll just like to summarize by saying that psoriatic arthritis is one of the spondyloarthritis. It may affect the joints, spine, or other organ systems associated with other conditions like obesity, diabetes, depression, and anxiety. There's increased risk of heart attacks and strokes. Unfortunately, there are no diagnostic tests, and therefore the diagnosis depends on a careful evaluation by a rheumatologist, and early diagnosis leads to better outcomes. Lots of therapies and very effective therapies are now available, and I think early diagnosis and early institution of such effective therapy can lead to long-term remission. Thank you, and I'm happy to take any questions.
Thank you so much. I'm happy to rejoin you here on the screen. So much great information, and we are so appreciative of your shared expertise and your insight. I do have several questions here. I know I won't be able to get through to all of them, and I know you touched on some of these, but I still wanted to ask them just so that those who did submit know that their questions are important. And the first question I have is, do you think that that psoriatic arthritis can actually be cured as opposed to just treated?
So once psoriatic arthritis happens and you treat it, and it goes into remission, then I don't think you can cure it completely. There are patients who go into remission, long-term remission, some of them on treatment, and once somebody reaches that state, we do gradually reduce treatment, and some of them are off treatment. But there is always that risk that it's going to come back. That's a problem with immune-mediated diseases, right? But therefore, I don't think a long-term cure is probable, but it is possible, especially if it's been diagnosed early. And then um, the question about preventing it, I mentioned about that. If you treat psoriasis early and effectively, would that prevent the development of psoriatic arthritis? Is an interesting question, and we're addressing that too. So I would say we can try to put it into long-term remission. Cure is it's a difficult concept.
For sure, it is. It is. And there's another question here, and someone says it's very frustrating living with this disease because others can't see it. It's not visible. Do you have any tips on how to manage this when people at work have the opinion that you don't look sick, so it can't be that bad?
So it's difficult, like you mentioned, when you have chronic pain, you're experiencing it, and it's hard for somebody else to kind of experience it, right? And so that also happens when you actually go to even healthcare settings, not just your occupational settings. So awareness campaigns, letting people know that nobody has to look sick to be sick for these diseases, not just psoriatic arthritis, but chronic pain conditions, other diseases, psoriasis, when it's on your trunk, for example, not visible outside, and the discomfort and itch that you have despite wearing clothes, the fatigue, the problems associated with stigmatization, etc., is a big problem. And the only way to get it is awareness campaigns, not just to psoriasis patients and family members, but also this is know it, that yes, it is a problem, but other people who are not aware of it, yes, this is a condition, it's a common condition. There are people around you that have it, which you're not aware, and be considerate. And if you get to know about it, then be considerate and give as much accommodation as possible to help them, be as productive members of society is really important. And I think individually it's going to be difficult, but from a community perspective, having awareness sessions like what we're having today would be the way to go forward. Yeah. Perfect.
Couldn't agree more. And the CSA is actively working on a national awareness campaign, which will be launching in the next couple of months. And so social media will be a big part of that. So we're going to ask people to get to become engaged with this campaign to help spread that effort of awareness. I have a question here, and it says, you mentioned that it can be passed through to family members. I have been diagnosed, but for my children, when should I have them tested so that they can benefit from early diagnosis?
So yes, family members are at a higher risk. Our own studies show that with psoriatic arthritis, if you have an immediate family member having the disease, you're about 30 times higher likelihood of getting the disease. So although that 30 sounds high, you're talking about the general population, so not but it is an important risk factor. So I would say being aware is important. So you're aware, that's great. And so when you're asymptomatic, first of all, if you have psoriasis, then that's like one signal that yes, you could develop psoriatic arthritis. Be aware of symptoms. Again, as I mentioned, you can have arthritis without the psoriasis. And so I think the best way to be is to be aware. And if there is any pain in the joints, the back, or the enthesis, so the heel, elbows, around the shoulder, pelvis, any kind of discomfort, pain present, say, for more than 6 weeks, that's what typically we say, 6 weeks is usually that window where the usual aches and pains kind of subside, right? That related to some injury or some minor complaint. But if you have persistent pain in these sites, then it'll be important to see your family physician or rheumatologist to have a proper evaluation. Like I mentioned, the studies show that 6 months is kind of it's better, delay of more than 6 months is a problem. The earlier the better. So we kind of, our Canadian Rheumatology Association goal is to get the diagnosis done within 6 weeks. So of the onset of 6 weeks from the referral and 6 weeks from the onset of symptoms. So I think 4 to 6 weeks of persistent symptoms would be the time when you should get evaluated. It may not reflect in the blood, but a good physical exam, appropriate investigations such as an ultrasound or maybe an MRI would help. And so it's a challenge given our health situation now with delays in getting to see doctors and investigations, but hopefully that'll improve soon and we can get there. So there's no time that you should go and get tested, but test when there is a persistent symptoms in these sites that I mentioned.
That's great advice. And, we talk about advocating for yourself and for your family members is something that we definitely encourage. So thanks for that advice. I have so many questions. I'm going to ask 2 more because I know we're hitting the hour mark here. It says here, I never know when flares will occur. Do you know how I can prevent flares?
Yeah, flares are difficult and not much well studied in psoriatic disease. We actually have a study now ongoing where we are asking patients to record their symptoms on an app, and we're asking them to carry an accelerometer that tells you how active you are, and we're also asking patients to give us a drop of blood every week on a piece of paper, and so then we can see how the symptoms are, what you're doing when you have those symptoms, and if there are changes in your blood markers. This is not a diagnostic marker, but markers of inflammation, which may or may not go up, right? So that will give us an idea of what these flares are, and then hopefully see what interventions can be used to prevent it. So typically, flares, you can do many things to do it. I have physician, one of our research partners is a physician and a patient with psoriatic arthritis, and so more insights both from a medical and from a personal perspective. And so she often says that she knows a flare is coming and she has to take rest for a couple of days to prevent that flare from becoming full-blown flare. Maybe knowing after some time you get to know what you should be doing to prevent those flares, and she takes rest for a couple of days. That helps a lot. Sometimes some anti-inflammatories, and also stress also kind of, and she realizes that some happens when you're busy at work or something like that, which if possible, if you can take a step back and relax, would help. Mindfulness and exercise does play a big role. And so I think the flare is quite personal to each patient, and so figuring out what is the trigger and trying to avoid it. Is it a particular food that you ate or particular stressful situation, and then trying to address that would be the way to go for managing these flares. And of course, the flares are persistent, then maybe, and you have full-blown flare that is, and the medications are not working. That's when we got to reassess on changing treatment, because many of these drugs, although work initially, many of them stop working after some time. And so that's something that you'll have to work with your physician to continue or to change.
I have another interesting question, and it says, my partner is healthy and active and really wants to travel, and I don't want to let her down. Do you have any suggestions on what I should consider to make myself more comfortable? I don't want to be a downer while on vacation. Very relevant question.
Yeah, again, that's quite personal. It's very hard to give an answer to that. As long as I would say it's both goes both ways, right? So yes, this person is concerned about partner, helping her enjoy her the partner's vacation and stuff. And I guess having that communication that you also have you'll also like to enjoy, but have these limitations, and both coming to a plan that can work together for both of them is something that needs to be done, right? It's getting the appropriate treatment, trying to keep the disease as well as and under control as possible, and then working together to kind of have a enjoyable vacation so that both of them take care of each other. I think that's the way to go forward.
Yeah.
Yeah, it's tough.
It is definitely challenging. I'm going to make this my final question, and there have been several questions posed around this specific topic. And so I'll just reframe it here. I suffer from anxiety and depression. Should I be concerned about using my medications and mixing them with my arthritis prescription?
So there are drug interactions that, depending on medications, the pharmacy will tell you, oh, maybe you shouldn't take these two together, right? And there are checkers for that, and you can work with your pharmacist and your prescribing physician to see that you get the drug that doesn't interact. So that's one thing for any drug that we do that. The other thing is about management of anxiety, depression. We know that, yes, anxiety and depression are a problem. Patients who have anxiety and depression are less likely to respond to the medications for the arthritis when we look at remission and other stuff. So, and we also know that patients with the mental health symptoms improve in many of the more with the advanced therapies that we use. So as the inflammation gets better and function gets better, your mental health indicators also get better. So that's a complex relationship. So I think acknowledging that there is a problem and getting that treated appropriately with your primary care or a psychiatrist would help. Getting on effective therapy for managing anxiety and depression would help. And effective therapy for your psoriasis and psoriatic arthritis would help. So it has to be and that's where I was talking about the combined clinics and specialists, etc., where that everybody's aware of all the conditions that you have and how that affects your, how mental health affects your disease and your disease affects your mental health. And treating both that together would be the way forward. And so you to get all your, specialists onto one page and to manage this. Sometimes it's difficult, but at least in our university hospital settings that we are able to do it. But maybe in the smaller community places, it's a bigger problem. So, but I'm glad that you kind of brought up that question and you're aware. Trying to work on it together would be the way to go forward.
I really appreciate that response, and keep asking questions, right? Keep
Yes.
asking those questions for sure. Well, as we wrap up here, I just wanted to thank you so very much for taking the time today to share about, this form of arthritis. We know that living with SPA can really take a toll on one's overall well-being, including their mental well-being, as you noted and as we've mentioned here. And so, flares can pop up at any time. They can be disruptive in daily life. Yet we know that, certain lifestyle changes can help to minimize the pain and swelling, just as you've mentioned here. And, it is a serious condition, and there currently isn't any cure. But as you said, there's hope. And with early diagnosis, that is really key. We talk a lot about empowerment for those who have been diagnosed and advocating for yourself. So we really want to, encourage people to keep asking those questions and keep talking, and let's reduce the stigma around this disease. So if you'd like more information for those who are watching this, resources on pain management, on movement and exercise, on mental health, or if you wish to seek support please visit the CSA website. That's sparthritis.ca. And we always say that there is a team of spa warriors ready and willing and wanting to support you through your journey. So thank you again very much for joining us, everyone.